You're listening to Conferences Online Allergy at Children's Mercy Hospital in Kansas City, Missouri. Today is January 26, 2024. Our topic today is Core Curriculum Hypereosinophilia, presented by Dr. Thao Lee. She is an Allergy and Immunology Fellow at Children's Mercy Hospital in Kansas City, Missouri. So the topic that I wanted to present on today for core curriculum was for hypereosinophilia, which may have jinxed myself because this was my topic even before I got the consult this week. But I feel like it's been coming up a little bit more in terms of our consult services or people who are active already and kind of having this kind of talking through. So hopefully Ishan and Sosa can watch this later. But we can go ahead and get started. And let me know if you guys don't see my slides. So before we get started, I think it's important to get familiar with some of the terminology for eosinophilia, hypereosinophilia, and then what is hypereosinophilic syndrome. Before we kind of talk about those numbers, when you get that consult about, there's elevated eosinophil counts, what you want to do is probably look at the CBC with diff yourself, because what you're looking at is the absolute eosinophil count numbers, not just the percentages. Sometimes there can be like false elevations in the or it'll appear like the eosinophil count is high because other cell lines may be decreased. And so as a result, you'll find that the absolute number will be normal, and they'll call this pseudo-eosinophilia. So if the percentage is high, but the absolute number is normal, you really don't have to proceed too much forward after that. And so the reason why we kind of want to look at these different definitions and why this may need extensive workup is because when you have elevated counts of eosinophils, they can cause like significant tissue damage, just cause a lot of chaos, and they can really just be like active systemically and affect several different parts of us. And usually it's because they can cause damage by either clonal proliferation of eosinophils, either by like a primary defect of stem cells or like a signaling defect, or there can be overproduction of cytokines that stimulate like eosinophilic production, such as IL-5, for example. So when we go through these definitions, eosinophilia is between 500 and 1500. Hypereosinophilia is more than 1500. And then when you think about hypereosinophilic syndrome, what you're looking at is like that persistent elevation of 1500 cells on at least 2 occasions, or if there's tissue hypereosinophilia or evidence of clinical manifestations that are attributed to the eosinophilia. So essentially, is there like end organ damage as a result of this hypereosinophilia that's present? So I think this slide, there's a lot to kind of go through, but I thought it was really helpful for me this week as I was going through my consult for hypereosinophilia. And I have a few additional slides after this to kind of go through some more specifics on this differential diagnosis that I think comes up in conversation a lot, but also some kind of important things to kind of touch on. So I would honestly, like, if you get a consult for hypereosinophilia and there's no clear etiology, Dr. Rajay had shared kind of an article of like how to approach it. And so there's kind of really nice little algorithms that you can look at before you actually go see the patient, because a lot of this, when you're looking at hypereosinophilia, requires like a staged approach. You need a really good history and physical, like everything else that we do. But because that history and physical can kind of help you find like certain pertinent clinical symptoms that may be present, organ involvement that may be there, and kind of help you kind of prioritize or kind of rank some of these differentials based off of what you think is most likely, because as you can see, some of the differentials is pretty broad, and so some of the workup also gets pretty extensive if you continue to not be able to find an underlying etiology. For us as allergists, what we'll always see is kind of like for patients with allergic diseases, you'll find that some patients you see in clinic have eosinophilia or even hypereosinophilia. So you'll see this potentially in patients with asthma, atopic dermatitis, and allergic rhinitis. Usually it's more mild, so like not like 10,000 all the time or anything like that. With patients with severe atopic dermatitis, it seems like those patients are the ones that are more likely to exceed the 1500. But something to consider is that when you have a patient who has severe atopic dermatitis and hypereosinophilia, they oftentimes also may have other kind of symptoms that are present. You should start to consider primary immunodeficiency as an underlying disorder. And there's another good article that I kind of referenced in here in the next few slides that kind of talks about different primary immunodeficiencies with related eosinophilia. And I think something that we've kind of talked about in clinic is even with atopic dermatitis is like, we see it greater than 1,500. With our patients with just severe atopic dermatitis, how high do you start to feel like comfortable, and then when you start to feel uncomfortable? And I think for some providers, I've kind of heard about 5,000, and that's when they start to be like, okay, yeah, they have severe atopic derm, but we still need to kind of maybe consider some of these other causes. But again, if there's the presence of other symptoms, I think that's going to change your risk stratification of when you should work up these patients a little bit further. The next thing I think that comes up into conversation a lot that we'll do for our patients are drugs. So drugs can also cause eosinophilia without symptoms, including medications such as penicillins, cephalosporins, and NSAIDs. A severe drug hypersensitivity reaction that may be associated with eosinophilia is drug rash with eosinophilia and systemic symptoms, or DRESS, which I'll talk about in the next slide. Something that you'll want to think about is that drugs are actually the #1 cause of like marked eosinophilia in the US versus parasitic infections are the #1 cause worldwide. So again, I think that's important to kind of garner through your history, because as you get this call, you may want to look through their MAR and you want to see, well, what medications did they start? What is more likely to cause this type of picture? And then like, when did you start seeing that eosinophil count go up? Because that may be helpful too in kind of asking about travel history. Let's see, I want to make sure I don't miss anything else. So as we kind of look on this chart here, you can see we went through allergic diseases, drug hypersensitivity, infections. We talk about helminth infections. Some of the ones that I've usually gotten in terms of for testing has been like strongyloides, trichinella, and toxocara. And we'll talk about strongyloides a little bit more too when we kind of delve into the treatment recommendations for these patients if they have suspected end organ damage and you want to start treatment before you can actually get a diagnosis. Some of these other ones here listed are like scabies. There's some other kind of protozoan, fungal infections, and viral. So HIV is something to consider for these patients too. I also feel like HIV is just notorious for being able to result in a lot of different clinical and lab abnormalities as well. Neoplasms, I think that's important to talk about. We've had cases of patients with like a secondary HES picture before due to their malignancy. And when we talk about HES and their variants, we'll kind of focus a little bit more on like the lymphoid and myeloid variants too. For the immunologic disorders, I did a few slides on some of these because these will kind of come up in terms of evaluation. You know, we'll get consults for like severe atopic derm, and sometimes you'll also find that they have hypereosinophilia. So I thought that would be good to kind of go over. But this would be like DOC8 deficiency, which is a type of hyper IgE syndrome. And then the previous like hyper IgE syndrome that you probably learned like early in med school or like even before that was Job syndrome, which is kind of what they call as like type 1. And then there's Omen syndrome, which we'll kind of sometimes talk about when we get our abnormal newborn screens, if they have that type of picture as well. Other things to kind of consider are like autoimmune disorders. So you can think about like IgG4 related systemic disease. You can think about kind of sarcoidosis, IBD. You can think about other like rheumatologic disorders with like vasculitis. And so I have one that kind of touches on that as well. But again, I think this chart is super helpful to kind of go through, and there's even more papers out there probably with other differentials that you can look at too. So the first one that I kind of just wanted to talk about a little bit further was DRESS syndrome. So again, this is the most common agents with this is going to be like anticonvulsants, antimicrobials, kind of like those sulfonamides, the penicillins, and cephalosporins like we talked about can do this. And then you also have allopurinol and minocycline. And so this usually occurs weeks after therapy and develops over days and may worsen after drug discontinuation. Some of these symptoms are facial edema, fever, lymphadenopathy, and hepatitis. And so when you get these patients that you're concerned about DRESS, you will likely do some blood work to see if they have any involvement of the liver, because it may be reflected there and they may not necessarily have symptoms. Typically for this too, If you're kind of on the fence, there is a nice little tool. I think it's on MD Calculator, but it's called Regiscar. And so you can kind of go through some of the symptoms that you find. On the right side, I kind of have a description of the rash. You can see there's some facial swelling there, but they also have this morbilliform type of rash as well. And the treatment is with systemic steroids usually. And for some of these patients, I've seen one before when I was a resident. And so it required like a really long taper of steroids. And I have seen it managed by dermatology, but again, the initial evaluation may come with us as we go through adverse drug reactions. So a little bit more. So this is just a few slides looking at like primary immunodeficiencies with related eosinophilia or hypereosinophilia. One of the first ones I wanted to talk about was autosomal dominant hyper IgE syndrome. So this is kind of like the type 1 form. So with this, as we kind of go through a BOS, you'll learn more about some of these different transcription factors that are important with signaling and stuff like that. But what you'll need to know is that for this specific type of syndrome, there's a loss of function in STAT3, which is a transcription factor that's essential in signal transduction of several different cytokines, such as IL-6, IL-10, 21, 22, and 25. So for these patients, it usually presents in the first few days of life, and they'll have a rash that will initially look like just neonatal acne or like erythema toxicum. So you know, PCPs or whomever or families may not think much about it because it's something that can happen with newborns as they get exposed to the outside world. But as they kind of get older, they'll kind of go through a lot of different symptoms. And there's a nice little dot phrase if you ever get these consults or new patient evaluations for hyper IgE that goes through a lot of the common symptoms that you think about as you kind of, again, risk stratify these patients for the likelihood of them having hyper IgE syndrome. Some of the clinical manifestations that you may see is that they also may have like eosinophils present in the skin that look like an eczematous dermatitis. They also may have what they call like cold abscesses, which makes sense now because when you like take the culture, it'll grow Staph aureus, but when you touch it and you look at it, it may not actually look like an abscess because it's cold. So it won't have that erythema, it won't have that warmth that you typically think about when you see like a gnarly abscess. Again, most of the time they're having infections with Staph aureus, but they can also have infections by strep pneumo and H. influenza, and they can develop pneumatoceles, and they're also susceptible to fungal infections. Some other clinical findings that are important in these patients compared to like the next type of hyper IgE syndrome that we'll talk about is that they also will have skeletal abnormalities. So as you can see here on the right side, they'll kind of have like characteristic faces where they'll have like a really prominent forehead, they'll have a broad nasal bridge, they'll have some asymmetry in the face. One of the things that they can also have is that they'll have retained baby teeth. So again, I've had to ask patients about that too when I evaluate them in clinic. And they also may have hyperextensibility of the joints and potentially scoliosis. They also may have osteopenia. So you want to ask them about like fractures that may have happened. So obviously some kids, you know, they may be on the monkey bars and they fall and get a fracture, but just start asking other questions of like, well, how did this happen? Like, was it a significant amount of trauma? Was it little? Because those may kind of change your index of suspicion as well. If it seems like, I would say, normal kid behavior versus not, meaning it didn't take a lot for that fracture to even occur in the first place. Some lab findings that may be present is eosinophilia. You may have elevated IgE, which is usually greater than 2,000, which again, I think is hard because a lot of our allergic patients too will have IgE greater than 2,000, but it's not like we're always looking and kind of evaluating for this autosomal dominant hyper IgE syndrome. So you really have to take into consideration what other things are present when you're seeing this patient. For these patients, they normally have a normal white blood cell count. They may have some associated neutropenia and leukopenia. Their other immunoglobulins are usually normal, and they may have a reduced or no response to specific antibodies after vaccinations. The next one is hyper IgE type 2 or DOC8 deficiency. So for this one, compared to the other, this is an autosomal recessive disorder. DOC8 is a guanine nucleotide exchange factor that's expressed in lymphocytes regulating the actin cytoskeleton. And as you can see here, it serves a lot of different functions and is integral for like cell migration, function, and survival of lymphocytes. These patients, compared to type 1 hyper-IgE syndrome, don't have the same degree of skeletal and connective tissue abnormalities. These patients will oftentimes have even more severe atopic dermatitis compared to the previous one. They also are more likely to have like anaphylaxis and food allergy. They will have recurrent sinopulmonary infections, but again, even though they have some Staph aureus, they kind of are more inclined to have them due to H. influenza or strep pneumoniae. The other thing that I think is important for this one to kind of note is that they can suffer from very severe viral infections that can also be disseminated, like HPV, HSV, VZV, and molluscum. Lab findings that you may see is, again, they may have eosinophilia, elevated IgE. These patients are also associated to have potentially more like hypogam or low IgM. They're more profound lymphopenia, and then they also can have decreased NK cells and impaired function as well. For treatment for this, the curative treatment is to do a stem cell transplant. However, there have been some newer studies of where while patients are waiting for like a transplant, they may be on dupilumab to kind of help alleviate their symptoms, again, because that atopic dermatitis can be really severe. And so it can potentially help them get until that point, which I know that we have a patient that does that currently. But you know, the other hard part is that a side effect of dupilumab may be also that they with VZV, so it's kind of hard because I think you're balancing both of those things. So that's the only other note I wanted to mention. The next one is Omenn syndrome. So again, I have not seen a patient with Omenn syndrome before, but it's something that we always talk about as we kind of go through the abnormal newborn screen. It's a form of a severe combined immunodeficiency that's associated with eosinophilia, and it's due to a hypomorphic mutation in RAG1 or RAG2. What hypomorphic means is that there's only a partially reduced function in the RAG genes, so it's not completely absent. And as you kind of progress through a BOS, you'll find that RAG1, RAG2 is important for like VDJ recombination. So when it's not functioning properly, you can have abnormal expansion of those T lymphocytes. These patients usually present in infancy with a rash that is generalized and often will look like more of a exfoliative erythroderma. It's kind of similar to that picture on the right side here. They'll have recurrent and severe infections. They may have chronic diarrhea, lymphadenopathy, and failure to thrive, and hepatosplenomegaly. So some of these other symptoms are going to overlap with like some of the other patients that we see with severe combined immunodeficiency, but that rash can be potentially characteristic, and then also looking at your lab work is kind of what's going to help support the diagnosis of Omenn syndrome. So the lab findings you'll see is potentially elevated IgE, eosinophilia, absent B cells, they'll have hypogam, and compared to SCID, when you look at your TBNK and naive and memory T cell panel, you'll find that these patients may actually have normal or even increased number of T cells, but they're illegal clonal, and so they're going to have a poor antigenic response. The treatment for these patients is also a stem cell transplant, and they oftentimes will require immunoglobulin replacement therapy as a bridge for their transplant, and sometimes, you know, they just need to grow a little bit more and stuff like that too. The last one that I have, I think kind of just touching base, going through our differentials, is eosinophilic granulomatosis and polyangiitis. So this is characterized by asthma, allergic granulomatosis, and vasculitis. Asthma is usually the defining feature and will usually precede the onset of vasculitis in most cases. Peripheral pulmonary infiltrates may be noted, but can sometimes resolve in half of these patients. These patients may also have paranasal sinus disease, such as nasal polyps. For diagnosis of this, the labs may show peripheral blood eosinophilia, but it can sometimes be normalized because for some of these patients that you're suspecting of a vasculitis, the treatment is typically with steroids. So with steroids, with eosinophilia in general, it can cause like pretty quick sequestration. So you'll see usually rapid improvement. Again, we'll talk a little bit more about the treatment because there are some circumstances where you may see them not responding to steroids. The other thing to consider is that only 40% of patients with EGPA will actually have p-ANCA positive on testing. So just because a patient is not positive or is negative for p-ANCA does not necessarily mean that they don't have EGPA. Ultimately, you should consider a biopsy because with EGPA, it is a small vessel vasculitis, so you'll be seeing necrotizing granulomas. But again, getting those biopsies can be challenging because you'll have to make sure you get the right spot, right? So you may still even miss it. But with this, treatment is usually with steroids, and more recently, you can also consider using mepolizumab as an IL-5 agent, anti-IL-5 agent for treatment of some of these patients. And I believe I've seen one on the adult side, and she's responded really well to mepolizumab. So kind of going back, so we've gone through our differentials, we've gone through all the different things that we can think of, we've done some of the lab workup already. So then we start to consider more of this hypereosinophilic syndromes. So these are the patients, again, that you're thinking of that has more than 1,500 on at least 2 different occasions, and they may have evidence of end organ or tissue damage. Clinical manifestations can be varied depending on the person, and sometimes they can be pretty insidious. But when you look at this chart here, some of the things that you'll find to be the most common are the dermatologic manifestations, which is typically more of like urticaria and angioedema. And then these patients also, after dermatologic manifestations, may present with pulmonary symptoms such as like wheezing, shortness of breath. Some of the more severe complications that can occur are with cardiac involvement or neurologic involvement. So the main cause of morbidity and mortality in AGS is going to be cardiac involvement. So when you have a concern for this, that's why you'll start screening patients with a troponin or potentially an EKG. For some patients, you may even consider getting an echo, but echoes can be normal in these patients a lot of times and may not be reflective of it, but it'll at least give you a baseline of their function if you feel like it's becoming progressive throughout their course. For other patients, they can also have neurologic complications, usually secondary to some sort of thromboembolic event, because as a result of the tissue infiltration with eosinophils, they kind of develop this inflammation, it becomes fibrotic, and then they can have kind of potentially strokes, they can develop encephalopathy, and then also peripheral neuropathy. So in the more severe cases, these patients may present with like cardiac symptoms and neurologic symptoms as a result too. So I took this chart from our board review book because I think it was a really nice summary of the different variants of hypereosinophilic syndrome. So the first one that we'll think about is myeloid variant. So for this, it's going to look similar to like our myeloid disorders. These patients will have hepato and splenomegaly potentially. It'll occur usually more in males, and I think for this one, you can see it a little bit more in older age populations, although you can still sometimes see it in children as well. They're at a higher risk for having cardiac complications. Some of the lab abnormalities that you may find is that there's an increased serum B12 or even a tryptase. They also will potentially have other lab abnormalities, again, because it's a myeloid disorder potentially. So they may have anemia, thrombocytopenia, and then they'll have kind of the dysplastic eosinophils as well. I think the genetics part of this is really helpful because this will kind of help you identify some of the treatment recommendations. So as you can see here, there's a deletion on 4q12, and so it can result in this FIPL1 PDGFR alpha fusion. And so I've done testing for that before, but with these patients, if you're suspicious of this variant or they have that known deletion or that you're able to find, you actually want to treat them with tyrosine kinase inhibitors like imatinib instead of necessarily just doing steroids first line. For these T-cell lymphocyte variants, so this results in a clonal expansion of aberrant lymphocytes, elaborating IL-5, and so these patients are usually going to be CD3 negative and CD4 positive. So I actually had to do this yesterday. So if you're looking for aberrant T-cells that could be causing this, after you get your initial flow cytometry, you would have to email the flow cytometry supervisor, and she can get the pathologist to do additional studies for you to look for any aberrant T-cells, and you can give him the specific CD markers that you're looking for to evaluate for that. But for these patients, the more prominent findings are going to be skin findings. So again, that urticaria, angioedema. For these patients, even though it may be initially benign, they can progress over to T-cell lymphoma. So they do require kind of like periodic monitoring. I think it was 6 to 12 months with repeat flow cytometry and all that stuff too. The lab features that you're going to find is potentially polyclonal cells, hypergam, elevated serum IgE and TARC, and then the abnormal T-cell immunophenotyping, which is why you can have the flow lab run additional studies, and the clonal T-cell receptor rearrangement. And so these are some of the lab abnormalities that you may be able to find that you would want to tie this with the lymphoid variant. For some of these other ones, there's familial HES. It's very rare, but it's because of an autosomal dominant transmission and associated with chromosome 5q31 to 33. Idiopathic is, meaning like it's multi-system involvement, but again, you have an undefined underlying etiology, which is, like a lot of other disorders. If we can't find a cause, it's idiopathic. Organ restricted means that it's specific to those signs and symptoms for the organ it's in. The lab features will be peripheral blood eosinophilia. So examples of this is like eosinophilic gastrointestinal disease, chronic eosinophilic pneumonia, and Wells syndrome. And then you also just kind of have this last one of defined syndromes associated with hypereosinophilia. So that's kind of like your other disorders, like EGPA, like we previously discussed. So for treatment, I have here, this is again in the same paper that I looked at. So when you have this, there's evidence. So I think the point to make is that if there's evidence of end organ damage or the patient is presenting with life-threatening manifestations, such as those cardiac abnormalities, and you see that eosinophil count being super high, then you don't necessarily want to wait for a diagnosis before you start treatment, because that can result in worsening symptoms and increase their morbidity and mortality. So if they have clinical manifestations that are life-threatening and you can't get everything done at once, because that's just sometimes how it is, then you may consider treatment with empiric high-dose steroids. If you're not sure of their history of if they have strongyloides or not, then you also want to empirically treat them with ivermectin, because if you don't and you just give steroids, it can result in disseminated strongyloides infection, which is also not good. The other thing to consider is that if you know that they have, for example, treatable secondary causes, or that you're concerned that there's more of the myeloid variant, then you can also, and there's a highly suspicious of that, or maybe you already know in their history that they have a myeloid malignancy, then you can do the imatinib instead as first line. But again, it just depends on what information is available to you. If there is cardiac involvement in addition to that, then you would do like imatinib and steroids as well. For this, improvement with imatinib is usually seen within 2 to 4 weeks of initiation of treatment. Again, if you don't have the clear etiology, then you would still have to do a bone marrow biopsy in order to definitively diagnose it. Second line therapies for some patients with the PDGFR negative variant is hydroxyurea and interferon alpha, but a lot of times patients have side effects from it, so they may not use it. Other biologics, so I think newer things to consider is that people have used like mepolizumab, I've seen before, and benralizumab, but I haven't seen that done. And that's it.